Okay, welcome everyone. My name is Hiva and I'm with Archer Review. And we are now, you should be able to see my screen, and we are now going live. But I'm going to let everyone kind of settle in and come in. And today we're going to talk about diabetes. So hopefully you have your lunch nice and prepared and in front of you, and you're going to enjoy this lunch with me today. I'm going to call it a lunch and learn. And if you've ever sat on one of my lectures before, you know that I like to keep it interactive. So open that chat box. I'm going to be asking you some questions, and you're going to answer my questions as well as ask your own questions so that we can make sure that we stay engaged and we're really absorbing some of this dense material. So diabetes can often be kind of dense. We will do a pharmacology review as well, but we're going to try to keep it as engaging as possible so you really retain the information. So before we get started, this slide here that you're seeing, you'll see this at the end of my presentation as well. We'll go over it at the end. We'll do a little Q&A, and we'll talk about all things Archer and answer any Archer related questions that you may have as well. But don't be worried if you can't get all this information down right now. I will go over this slide again at the end of our presentation. But for the purposes of time, because we have a lot to cover, I'm going to get started. So we are covering endocrine today, and we're going to focus on diabetes. So before I really get in depth on diabetes, I want to make sure we're all on the same page. So we're going to do a really quick overview of glucose metabolism. So what is normal glucose metabolism? What happens when someone without diabetes eats something or ingests food, right? So we're not talking about abnormal glucose metabolism, we're talking about normal glucose metabolism. Your body takes that food, breaks down the carbohydrate, and that carbohydrate then breaks down into glucose and goes into your bloodstream. What the body then does with that glucose in the blood is it releases insulin from the pancreas to help that blood glucose get into the cells. And that is what allows the cells to then produce ATP energy. So it gives our cells the energy they need. So the other thing that's happening at the same time, another organ that's involved in this process is your liver. So if you don't have enough blood glucose, that liver is actually going to be releasing some glucagon as well so that it can increase the levels of blood glucose and maintain that homeostasis, right? So this is really important to understand because as we're talking about diabetes and what's happening in the body and the different medications, a lot of it is involved in different parts of this process. So I've really simplified it for us, but it's really not that simple, right? The other thing I wanted to highlight is that really the insulin, I want you to think about that insulin as the lock and key. So the insulin is really what helps our bodies take that glucose from the bloodstream and get it into the cells. So we'll talk a lot about that as we get into the medications and when we briefly talk about type 1 diabetes as well. And I forgot to briefly mention that our wonderful Rachel is also on this webinar today, and she's going to be assisting on the chat. So if you have any questions and I don't see it because I'm chit-chatting or presenting something, she'll help us out in the chat as well. Okay, so don't be afraid to ask your questions. So now that we've talked about normal glucose metabolism, let's talk a little bit about abnormal. What happens in the body when the patient has diabetes? So diabetes is when we have chronically elevated blood glucose levels, right? And it can happen for different reasons. In type 1 diabetes, that's an autoimmune condition, and we're not quite sure why some patients develop type 1 and some patients don't. But it is an autoimmune response, and the body starts to attack its own beta cells in the pancreas. So it starts to destroy those beta cells. Type 1 diabetics sometimes still have some beta cells before they're all destroyed. So some of them do produce some insulin, but it's really just not enough. And what happens is they start to get really sick, and they get sick quickly. And oftentimes they're diagnosed in the hospital on the inpatient side, or they get admitted for being sick. But basically, the body attacks its beta cells. And then what you should know for your boards is it happens in about 10% of the cases. So most of the time, it's most common in childhood, even though we are seeing it more and more in adulthood as well. As clinicians, we're getting more educated on how to diagnose it in adulthood. But for the purposes of your clinical practice and your boards exams, just think about type 1 diabetes as really common in childhood. And so it peaks between the ages of 4 to 6, and then again in early puberty. So any time before age 10. So keep that in mind as you're thinking about these clinical cases that you're presented with. Is this potentially type 1 or type 2? And we'll talk a little about that when we're talking about the diagnosing of the type of diabetes it is. Now, type 2 diabetes is probably what you're more familiar with. It's certainly going to be what you're going to be managing more as a primary care clinician. Unless you choose to go into specialty, you're going to be managing the more simple type 2 diabetics. So it's important for you to be comfortable with screening, assessing, diagnosing your patients, and really managing these patients. So this is more of a metabolic dysfunction. So we have some resistance. Remember that lock and key that we talked about? So we have some insulin resistance. So our cells are getting a little resistant towards accepting that blood glucose and producing into ATP, into energy. And then we also have some insulin deficiency. So over time, that pancreas is pumping out all this insulin and it gets fatigued. It gets really tired. So we start to not produce as much insulin and we get a little insulin deficiency. This is about 90% of the cases. So this is what you're going to see most often in your clinical practice. Now, let's talk about some common signs and symptoms of diabetes. They're going to be the same whether it's type 1 or type 2. And we'll talk about why that is, but let's think about it for a minute, right? So if you have really high blood glucose levels, your body is going to try to correct that. It's going to say, whoa, this is too much pressure on those arterial walls. It's too much pressure on those end organs. We need to lower this blood glucose level. So it tries to dump it. And so how does it try to dump it? First thing it does, it really tries to dump it through the kidneys. So it tries to increase your urination, right? So those patients are going to be urinating a lot. And what goes with those big glucose molecules are big water molecules. So it pulls the water in the urine. So then those patients start to get really thirsty. So we see the increased thirst as well, right? And so with that, as they're starting to pee all this water and glucose, it's a nice breeding ground for infection. So we might see some skin infection or some yeast infection in the genital area. Also, same, why slow wound healing? So if you have high blood glucose levels, you have a lot of blood glucose, a lot of glucose in your blood. So when there's bacteria feeding off of that glucose, your body's going to take a lot longer to fight off that bacteria. That bacteria has a food source, right? So you're getting that slow wound healing, that delay wound healing. And then the blurred vision, it's actually because you can get buildup of glucose on the lens in front of your eye. So that's actually buildup of glucose when we see our diabetics saying they're experiencing blurred vision. So that always worries me a little bit. And then fatigue, why are they so tired if they have all this blood glucose? Well, it's not actually getting into the cells to produce energy. It's just hanging out in the blood. So they're tired and the cells are exhausted. The body is really craving energy. It's not getting the sugar it needs, not getting that glucose. So what does it start to do? It starts to break down its fat reserves to try to get that energy. So we initially see weight loss in those diabetic patients. So I always get really worried when my diabetics come in, they're like, oh, my diabetes is doing great. I've lost all this weight and I haven't even done anything. And then I get really worried. I'm like, oh gosh, let's look at those blood glucose levels. Let's see what's going on. Like, is this your body's way of trying to get that energy it needs, right? Because it's not getting into the cells. And then, of course, if they're losing weight, then they're going to be more hungry, and it just kind of feeds that cycle. So these are why we see these common signs and symptoms in diabetes. And so you not only want to ask these as screening questions when you're initially thinking about diagnosing, but as those patients come in for their routine follow-ups with you, you want to be asking these questions because it'll really give you a clearer picture of how well controlled their diabetes is, right? So I know you guys are all going to do a great job with that. So now let's talk about diagnosing. So now that you know this patient has diabetes, first we're going to let's back up. First, we're going to diagnose them with diabetes, and then we're going to break it down into, is this type 1 or type 2? So how do we diagnose them? You can see the diagnostic criteria is the same for both type 1 and type 2 diabetes, because again, it's chronically elevated blood glucose levels. So a hemoglobin A1C over 6.5%, fasting blood glucose over 126, a 2-hour plasma glucose glucose over 200 or a non-fasting glucose, same as the 2-hour over 200. So that's going to be the diagnostic criteria, and you can safely diagnose that patient with diabetes if they're meeting that diagnostic criteria, any one of those. And then you want to see, well, is this type 1 or is it type 2? How do I know? Well, the trick here, the tricky thing is there's no set criteria between type 1 and type 2. So it gets really complicated, especially in patients that are kind of in this gray area. But we have to use a combination of clinical presentation, patient's history, and then support that with some labs, right? And so let's talk a little about that. So the clinical presentation, and this is typical, and there are some patients that fall out of these typical presentations. So I want you to keep that in mind. But for the purposes of the boards, when they ask you, don't look for the zebra, they're asking you straightforward questions. They want to make sure you can recognize this. The clinical presentation for type 1 diabetics, it's going to be early childhood, again, before the age 10, before early puberty, and it really peaks between ages 4 to 6. And think about that. So a 4 to 6-year-old, how are they going to handle a diagnosis of type 1 diabetes? How is their family going to handle that? That's really tough, right? And then so clinical presentation in our type 2 diabetics, typically this is more in puberty. Their body habitus is different. They're usually overweight or obese. They might have other comorbid conditions, PCOS. You might see the acanthus nigrans on their neck. They might have not pre-diabetes. They might have hyperlipidemia, hypertension. They might have some other things going on, right? And those type 1s are typically going to experience more of the weight loss and look more small. And I don't want to say frail, but definitely smaller. And then for history, so what are we looking at? So we know that autoimmune conditions run in families. So asking the questions, is there anyone in your family with autoimmune conditions? So that's going to be a big red flag for that patient. Does that patient have a different autoimmune condition? Because that also puts them at increased risk, right? And those type 2 diabetics, their family history is going to look the same as what we talked about with their body habitus. So they're going to have a big family history of all those comorbid conditions that we talked about: metabolic syndrome, hypertension, hyperlipidemia, diabetes. So that's what their family history is going to look more like. And then with labs, so I put these labs under type 1 because that's really going to be your supportive labs if you're really thinking type 1. But most patients with type 1 have one or more of the pancreatic antibodies. But the trick here is, so can type 2s. So that doesn't really help us, right? And then with the insulin and C-peptide levels, that's going to be a little bit more helpful, because in those type 1 diabetics, we're going to see low or inappropriate levels, fasting levels of the fasting insulin, right? Because it's really attacking those beta cells. They're not producing enough insulin. They might be producing some, but not enough. So that's really going to be helpful in diagnosing those type 1s. And then same with our type 2s, we're still going to see high levels of that fasting insulin. So we're seeing more of that insulin resistance, right? So that's going to be helpful. But remember, when you're diagnosing, know these general rules for your boards exams and in clinic, but you're really going to send those type 1 diabetic patients off to endocrinology. You're not going to be managing these patients. So you can always have endocrinology confirm the diagnosis, or if they're coming out of the hospital, they're going to go straight to endocrinology anyways. So again, a brief overview of hemoglobin A1C. This is your average blood sugar over the span of 3 months. So please don't check it more regularly than 3 months. It's going to get kicked back by insurance. Patients will get really mad at you because they'll come in with a high bill. And then also coordinate with all the patient's providers. So if there's another provider already checking these A1C levels, you can use that. You don't need to redraw it, right? And so normal A1C is going to be less than 5.7%. In our pre-diabetic range, that's going to be 5.7 to 6.5%. And when we're getting over that 6.5%, then we are in that diabetes category. Now, I want to focus on pre-diabetes because that's also something that we as primary care clinicians need to really be focused on, because pre-diabetes is where we have to really be thinking about preventing this patient from developing diabetes. And so one of the biggest risk factors is being overweight or obese. So if you look at the studies, it's really kind of, I don't know how to describe it, but it's kind of amazing to see, like, if a patient is overweight and obese, that adipose tissue or the fat actually builds up on that lock and key. So the insulin, that's how they start to build that insulin resistance. So really being overweight and obese is a huge problem. It does lead to diabetes. So we really want to talk to patients about that. And I know it's a sensitive subject. A lot of patients may not want to hear it, may not want to talk to you about it, but trying to explain to them that their weight does play a big role in their overall health is going to be really important in helping prevent those complications down the line. So talking to your patients about losing weight if they're overweight or obese, talking to them about their physical exercise, their activity level. Are they sedentary all day? Are they getting up and moving? What do they do for exercise? Let's talk about it. And then talking to them about their caloric intake and their nutrition. Do they need some extra help? Have they been eating out a lot, fast food? What does their diet look like? Are there sodas involved, sugar in their coffee? We really need to look at the whole picture on how to help these patients prevent them from developing diabetes. That's going to be big focus for us as primary care clinicians. And the increasing age, of course, that's a risk factor that they can't modify. So yes, we become more insulin resistant as we age, but we want to really focus on those modifiable risk factors. And of course, genetics, race, ethnicity, all that plays a role, but we're going to focus on those modifiable risk factors to help prevent them from developing diabetes. Now let's quickly focus a little bit on gestational diabetes, because you'll see this probably pop up both in clinic if you work for like a federally qualified healthcare center. I know we had an OB clinic within our clinic, and then if you were a primary care provider there, you would see the OB patients and they would occasionally rotate through the OB clinic. So you may be seeing these patients yourself. They may be seeing OB if you're in a different outpatient primary care practice setting. But you should know this generally for the boards as well. So we're going to go over it. So in gestational diabetes, can anyone tell me, and I'm going to open my chat box, but can anybody tell me why we screen our pregnant moms towards the end of that second trimester? Does anybody know? And don't be shy, please. I always love to hear from you guys. And this is a safe space where we can chit chat and talk. And I rather you get it wrong here and get it right on the board. So really, don't be afraid to engage with me today. I would love to hear from you. So why do we screen these moms? Does anybody know? To prevent big babies. That's good. Yes. Excellent. Anybody else? So Angelica, it's along those lines. So I'm glad you said that. So we screen moms because if you look at the physiology of pregnancy, the women's bodies are actually really insulin sensitive in that first trimester. So that's why you're getting all those morning sickness symptoms. It's really insulin sensitive because the body is designed to really take the glucose and feed mom's body. So she's going to be really insulin sensitive. So she's going to be hungry, increased hunger, increased nausea, fatigue. She really is insulin sensitive. And then by second trimester, she becomes insulin resistant because the body then shifts gears to then not feed mom, but feed baby. So that's what ends up happening in second trimester. And that's why some of our moms start to have difficulty with that process, with that insulin resistance, and they may develop type 2, they may develop gestational diabetes. So that's why we screen right between the end of that second trimester to catch those moms, the bodies that are having difficulty with that insulin resistance, because as Angelica said, we want to make sure baby is growing in a healthy way and there are no complications to baby because of mom's difficulty to manage those blood glucose levels. So awesome job. So how do we diagnose gestational diabetes? This might be something that comes up on your boards. So knowing the diagnostic criteria is going to be helpful to you. We do a 1-hour glucose tolerance test. Typically, it's an oral glucose tolerance test. And who can tell me if they fail this 1-hour glucose tolerance test, can we then diagnose them with gestational diabetes, or is that not enough? What do we think? Exactly. You guys got it right. So it's not enough, right? So remember, this is a screening test. We're just trying to catch those moms that are having difficulty with that insulin resistance. So if they fail that 1 hour glucose tolerance test, it doesn't mean they have gestational diabetes. They then have to do additional testing to then meet the diagnostic criteria for gestational diabetes. There are 2 hour and 3 hour glucose tolerance tests. Typically, 3 hour is the most common. That's what you'll see. And mom does have to fail 2 or more of the values. So these are the values that they check at that fasting 1 hour, 2 hour, 3 hour. And she does have to fail 2 or more in order to meet the diagnostic criteria for gestational diabetes. So awesome job. You guys all got it right. So let's practice. Again, I love these practice questions because it really helps solidify the concept. The nurse practitioner is reviewing the lab results for a 24-week pregnant patient. The result of a 1 hour glucose challenge test is 140. Which of the following is appropriate in making a diagnosis? So is it A, you want to then order the 3 hour glucose tolerance test? Is it B, order a hemoglobin A1C? Is it C, review a fasting and a 2 hour postprandial blood glucose level? Or is it D, you would diagnose her with gestational diabetes based on that 1 hour glucose challenge test? What do you guys think? Good. Awesome job, you guys. Yes. So the answer is A, you would order that 3 hour glucose tolerance test. Because again, that's just the 1 hour is a screening test. It does not mean that you can diagnose her with gestational diabetes. Why would you not order an A1C? Isn't that less, not invasive, but doesn't that take less time? And, it's easier on you and mom. Well, A1C is not going to be very helpful because, again, remember, it's that average of 3 months, and we're looking at the end of the second trimester. So she might have been fine early on, but now her body's a little bit more insulin resistant and having trouble with getting the insulin to where it needs to go. I'm sorry, getting the blood glucose to where it needs to go. So that A1C is going to be helpful in managing the gestational diabetes, but it's not going to be helpful in diagnosing it. And then same with those blood glucose levels, it's just not the standard of care. We do want to use that oral glucose tolerance test. So awesome job, you guys. It says, I don't have the box to answer the questions. So you just need to answer in the chat box. That's all. So where you just type that is where you would put your answer. So don't worry about the Q&A section or any other sections. We're just having a nice casual chat today. So go ahead and throw your answer in that chat box. Great question, Jasmine. So now I'm going to talk to you guys a little bit briefly about type 1 diabetes. Again, you're not going to be managing this unless you go into endocrinology as a specialty, but it's good for you to know about type 1 diabetics. And so in these patients, insulin is required because remember, those beta cells have been destroyed, so the pancreas cannot produce insulin or enough insulin. So they're going to need insulin around the clock or they're going to get really sick, right? So they're going to need basal insulin in the background along with prandial insulin at mealtime. And it's good for you to know the difference between these insulins because you will be using these insulins in type 2 diabetics. So I'll give you a practice question next on how you may see this information pop up on the boards, but it's good for you to get comfortable with different types of insulin and how you would be managing it and prescribing it. But in these patients, it's good for them to go to specialty, to go to endocrinology, because endocrinology really has a lot of different tools that they can provide these patients to help manage their diabetes. So they have glucose tolerant, continuous glucose monitors. They call them CGMs. I've worn them myself, and they're really nice because it helps connect to a phone. You can see that patient's blood glucose continuously. Some of them you have to scan, but now the newer ones, it's really a continuous monitor and you can keep it on for up to 14 days. And it really helps those patients, especially if they have an insulin pump, it talks to the insulin pump and it helps those patients manage their blood sugars without having to guess or always just going up and down, up and down. And those providers are trained in reading those reports and helping those patients make tweaks in their treatment and their pharmacology. So there are really some great devices. If you get your hands on CGMs for your type 2 diabetics, it does really help with, I would say, I don't want to say meal or portion control, but it does definitely help with lifestyle modification because then patients can really start to see, oh my gosh, I ate this and I thought it wasn't that bad. And then look at what it did to my blood sugars. So it's a really nice tool to use, even if they don't have to wear it all the time, but maybe they wear it right when they've gotten diagnosed and you're working with them on the nutritional piece. If you are in a patient demographic or treating a patient demographic that can afford these CGMs, or if their insurance covers it, it's a nice tool to use to really help them get a better understanding of what's going on with their body. And then, of course, with these type 1 diabetics, we definitely want them in nutritional counseling, especially when they've first been diagnosed, because they really need to start to know how to carb count, to manage their insulin. And then, like I said, we're going to be referring them to endocrinology. All right, so let's practice, and I'm going to let you read this question on your own. And like I said, you just want to put the answer in the chat box. It's a little bit of a wordy question, so take your time with it. I'll give you a few minutes, and then just put what answer you think in this chat box for me. Good, I'm seeing the answers come through. Give you guys a couple more minutes. Don't be shy. I know it's a little wordy. Awesome participation. You guys are a great group. All right. So the answer is C, and let's talk a little bit about why the answer is C. So we're going to go back to this slide. So remember, this is a type 2 diabetic, and they've been on oral medications, but now you're going to start them on insulin just to give them a little boost, a little help, because the oral medications are not getting their A1C down to goal. So 9.5 is too high, right? We want to get them under 6.5. Our goal is to really drive down that A1C. So the nurse practitioner is starting the insulin. So they're telling you what kind of insulin. And Lantus is a basal insulin, it's a long-acting insulin. So that should give us a clue, right? We know right off the bat how we're going to prescribe this insulin. So choice A says you would give 5 units sub-Q before breakfast and at bedtime. Well, first of all, we're not going to be giving this twice a day. So Lantus is long-acting, it's given once a day. So we can already rule that out. It's not a prandial insulin, right? And then choice B, 5 units sub-Q before each meal. Again, it's not a prandial insulin, so we're not going to be giving it throughout the day, 5 units, 5 units. It's just a one-time dose. So that brings us down to choices C and D. Now, this is where it gets a little tricky, and they're trying to catch you on this, and this is going to be the safety part of this question. They want to make sure that you're going to be a safe prescriber. So you might think, okay, there's a calculation for insulin. I saw this when I was studying, when I was practicing. I know how to calculate it. They've given me a weight. So I think they're trying to trick you here a little bit. They've given me a weight, so they want me to calculate the insulin. So you calculate and you see that, yes, this patient's going to need 18 units every 24 hours. Well, that may be true eventually, but you do not want to start a patient on 18 units right off the bat. They're going to tank. So you would never start a patient on more than 10 units a day when they've initially started. You may then titrate that insulin gradually by 1 to 2 units every 3 days, and they might get up to that 18 units, but they're not going to start on 18. That's not safe practice, right? So this is definitely a safety question. And a lot of the pharmacology questions as you're studying, just think about the safety, think about the contraindications and when you would and when you wouldn't do it. A lot of those pharmacology questions are going to be around safety. They want to make sure you're a safe prescriber. But you guys did an awesome job. I love the participation and you got it right. So I'm really proud of you guys. That was a hard one. I think that was a tricky one. All right, so now we're going to talk and focus on type 2 diabetes, mostly pharmacology. We're going to do a nice pharmacology review for you. Before we get into that, I want to talk to you a little bit about the guidelines that are available to you. I know sometimes it can feel daunting. You have all these different classes of medication now available, which is great, but it's also like, well, where do I start? I want you to know that there's 2 main sources that are really helpful, and give you algorithms and guide you on how to select the appropriate medication regimen for your patients. So we have the ADA, the American Diabetes Association, and then we also have ACE, the American Association of Clinical Endocrinologists. And so both of these are going to be really helpful when you're trying to decide on which adjunct medication to add to that metformin. So hint, hint, metformin's always going to be your first line unless contraindicated, and we'll talk about that. But I like these two guidelines or these two sources. I have them saved or bookmarked myself. So you always want to reference the evidence because we are evidence-based providers, right? So now let's talk about the medication. Let's talk about sulfonylureas. We're going to start here. This is the oldest class of anti-diabetic medication. It's the cheapest, but it is falling out of favor. And why? Look at that huge red arrow about hypoglycemia. It is falling out of favor because of its hypoglycemic side effects. So these are going to be your medications that end in I. So you're going to have glyburide, glipizide, glimepiride. So these medications really help increase the release of insulin from those beta cells. So of course, they're going to be contraindicated in type 1 diabetics who don't have healthy beta cells. And then it also affects that insulin metabolism through the liver, decreases that glucagon secretion, increases that insulin sensitivity. So it does a lot of really great things. But then we do have that big hypoglycemic side effect. So we want to make sure we're definitely educating patients to take it with meals when they're taking it. Do not skip meals. And we really want to educate them about hypoglycemia awareness. And I'll finish that up, or that'll be my last slide in today's presentation too. But you want to make sure your patients understand the signs and symptoms of hypoglycemia and they know what to do when they're having those signs and symptoms. So we call that hypoglycemia awareness. And then you want to document in your chart that if you're prescribing this medication, the patient has been educated on hypoglycemia awareness. The other side effect to note here is you want to watch for weight gain. So sulfonylureas do have that as a side effect. So this might not be great in a patient who's trying to lose weight, which most of our diabetics are. So it's, not the best medication, but I still do see it used out there. So something to be comfortable with managing. Now, these are TZDs, and I'm going to try to pronounce it for you, even though I've tried many times and it's really hard to pronounce, but your thiazolidinodoins, but we call them TZDs. These are the suffix, the glitazones. And so you're mostly going to see Actos out there, but we do have two different medications in this drug class in our TZDs. And the way they work is it improves insulin sensitivity by breaking down that glucose in the fat molecule. So it also helps co-manage cholesterol. So it's really nice in that sense as well. But biggest side effect, and this is a serious side effect, it does increase, the way it works, it increases that reabsorption of water through the kidneys. So as a result, you get fluid retention in these patients. So fluid retention, weight gain, you do have to monitor for signs of CHF, right? So we want to make sure we also educate our patients about signs and symptoms of CHF. And if they're experiencing any while on this class of medication, they need to tell us right away. We do have a contraindication in CHF. So if a patient's already diagnosed and being treated and managed for heart failure and they're in classes 3 to 4, we cannot start the patients on this class of medication. We also cannot start in patients with liver disease or osteoporosis because it does have an impact on those body systems as well. So with these patients, you definitely want to be checking those LFTs and making sure that if you see any increase in those LFTs, it's not coming from the TZDs, right? And then so these medications do take a while before they reach their max effect. So you don't want to titrate it more than every 4 weeks. And then again, the biggest thing here is you do want to watch for signs of heart failure. And that's going to be the biggest takeaway with TZDs. Now we're going to talk about biguanides. So there's really only one medication in this class, metformin. It's my favorite one. Generic name is glucophage. Patients tend to either love or hate this medication. I don't think it gets enough appreciation, but I think metformin is a really safe medication. It's low cost and it's effective. So I really want you to not skip over metformin. We're seeing that a lot now that our GLP-1s have come out. out. And I really want you to give metformin the time that it deserves when you're talking to your patients about their type 2 diabetes treatment. So how does metformin work? It helps reduce that hepatic output of glucose from the liver. It also decreases the absorption of glucose from the intestines. That's why we get all those GI symptoms. That's what patients hate about it, and that's why they don't take it. And then it also helps increase the uptake of glucose in those peripheral tissues. So it really helps with that lock and key mechanism. It helps those cells with that insulin resistance, and the blood glucose goes into the cells, and it lasts for a long time. It really stays in the body even once the patient has stopped taking the medication for up to, I think, like 3 to 6 months. So it's really effective. You're not going to get hypoglycemia the way you do with sulfonylureas. So that's not how it works, but it really works on a cellular level for these patients. So it's a great medication. It's a great drug. If you can get your patients to stay on it and tolerate the side effects do go away. So it's good to educate them on that. And then you want to always start low and go slow. So I have patients who come in and say, oh, I couldn't tolerate metformin because of the side effects. Dig a little deeper, you find out somebody started them on 1,000, 1,500, and of course they couldn't tolerate the side effects and they stopped taking it. So always start on the 500 once a day with their biggest meals. Talk to them about what they're going to experience, and it's going to be normal with nausea, loose stools. That's all normal, right? And so they shouldn't stop taking the medication. They should stick it out. And then after 3 or 4 weeks, they can bump it up to 1,000. So 1,500 in the morning, 1,500 at night if they're continuing to tolerate it. And you can even keep them on that 1,000. That's great. If you can get them up to 1,500, that's great. You don't have to go to the max of 2,000. That's, not necessary to get the benefit of this drug. So really work with your patients on trying to get them to be consistent with this medication because it works so well. Other contraindications or some contraindications to talk about. There is some contraindication with renal impairment, but that's mostly in our elderly patients with really chronic end-stage renal disease. So it is a pretty safe medication. There is the risk of lactic acidosis. So there used to be another medication in this class on the market. It was called fenfermin, I think, and it was previously available, but they did discontinue it because of the lactic acidosis. So you just want to make sure you're not prescribing in patients with renal impairment. That's all. Okay, so come to our next practice question. I'm going to read this one for you because it's not as wordy. So in planning pharmacologic treatment for a geriatric patient with diabetes, which of the following should be considered? So remember, we're talking about a geriatric patient. So again, they're going to be asking for a safety question here. So A, would you start them on a sulfonylurea? Should that be your first line therapy? B, are you going to start them on Lantus? Or are you going to start them on insulin as your first line therapy? C, you're going to start them on a combination of glipizide and metformin as your first line recommendation? Or is it D, single medication therapy with metformin? What are you guys going to do? I love that, Jasmine. Thank you. That means that even when you're not sure, you're participating. That's wonderful. And we'll talk about the rationale. So you guys are doing great. So the answer is D. So you guys, almost everyone got it right. And I love that. So you're definitely going to be safe providers. Why is the answer D? So metformin should always be your first line, especially in patients who, again, don't have that end-stage renal disease, renal impairment. Like, it's really a safe medication. So in this geriatric patient, out of all these choices, this is the safest medication to start them on. Why would you not start them on the sulfonylurea? Because of that hypoglycemic risk. So that's really dangerous in our geriatric patient population. We don't want them to have hypoglycemic episodes and faint and pass out and break a hip. We would never be starting someone on insulin as first-line therapy unless they're a type 1 diabetic. So you could already rule that out. And again, we would never be starting someone on combo therapy. You always, good practice across the board, not just in endocrinology or diabetes, but across the board. You always want to start with one medication, max that medication out before you add a second agent. So that's going to be the best practice moving forward, right? So great job, you guys. So you don't know where to start? Look at metformin. It's a great place to start. Yes, so that one was tricky. So that's why I wanted to emphasize, Jasmine, that the biguanides are contraindicated in elderly patients who have renal disease, like chronic end-stage renal disease. So it's not contraindicated in elderly altogether. So that was a little bit tricky. I agree with you. When I was putting that question, I was thinking about that, but I was trying to hit it hard on that metformin page. But that's good feedback. So I'll hit it a little bit harder. So it's not contraindicated in our elderly patient population. We just have to watch for that renal impairment. So great question, Jasmine. All right, so our SGLT2 inhibitors, these are going to be your Invokana, Farxiga, Jardians. With this class of medication, it really helps decrease the absorption of glucose in the kidney. So most of where we're going to see how it works, the mechanism of action is really in the kidneys. It helps promote that glucose excretion in the urine. So of course, the side effects are going to be increased urinary output. This is common. Talk to your patients about it. They should expect it. What do we need to be mindful of as clinicians when we're prescribing this medication is that they are at increased risk for infection because of that glucose coming out of their urine, right? So we talked about that when we're talking about signs and symptoms. So we want to make sure we're screening. What I like to do is do a urinalysis at each visit when I know patients are on these SGLT2s. And then you can always document when you see high glucose levels, but no signs of infection. You can say it's because they're on an SGLT2 inhibitor. That's an expected finding, but I don't see any findings of infection. So you want to make sure you're ruling that out. We do also want to watch for hypovolemia. So again, in our elderly patient population, we want to watch for that. And I stress that because once our patients do age, or as they're aging, you want to look at their medications each time and see if they need everything that they're on. You might want to take that patient off their SGLT2 inhibitor if their A1C goal is between 7 to 8, right? Because you don't have to be as tightly controlled with our elderly patient population, and we want to avoid those side effects. The other benefit of SGLT2s are weight loss, so that can really help in our younger patients who are also looking for that added benefit of weight loss, so that's really helpful. But again, biggest takeaway for SGLT2 inhibitors are those signs for dehydration as well as infection. Our GLP-1 agonists, so these have been getting a lot of attention lately. They are really great medications for helping with weight loss, but they are also anti-diabetic medications, right? So before they were approved for weight loss, they were approved for diabetes. And so what do SGLP-1s do? So what is the role of SGLP-1 in the body? Well, it's a GI peptide that releases in response to when you eat food, your food intake. So it helps stimulate the release of insulin. It slows that gastric emptying. It decreases the glucagon secretion, and it increases satiety. So all those things sound pretty in line with the use for weight loss, right, in our non-diabetic patients. So again, with this, the side effects are going to be mostly GI because that's where it's really working. And we want to watch for pancreatitis. It is an injectable class of medication. There are some oral of this medication as well, but the ones that are injectable, we do have to educate patients on rotating the site and looking for site reactions. So you want to make sure that they're not getting that hardening under the skin. And then there's one thing, there are a couple things I wanted to flag about this class of medication. So there is a risk of thyroid cancer. So we've seen in rats, GLP-1s show thyroid C-cell tumors, so including medullary thyroid carcinoma, but we haven't seen the risk in humans, but we cannot prescribe this in patients with either a personal or family history of this type of thyroid cancer. And you want to make sure you're documenting that in your chart when you're starting patients on this medication, that you've asked that screening question and there is no personal or family history of that type of thyroid cancer. Okay, that's a big contraindication. The other thing to look out for as we're seeing, we're using this class of medication for weight loss and we're seeing more research come out, the FDA is currently investigating, evaluating reports of suicidal thoughts or ideations related to patients on GLP-1s. So there's been no evidence found yet, but something that we have to keep an eye on. And in these in patients where I'm also treating them for depression, anxiety, I talk to patients about that, and we keep a close eye on that when we're starting them on a GLP-1. So that's something to keep in mind as well. Now, our DPP-4 inhibitors, so what is the role of DPP-4 in the body? It inhibits the GLP-1 peptide. So if we inhibit DPP-4, then we're going to allow for that GLP-1 activity. Does that make sense? So if we're putting someone on a DPP-4 inhibitor, we can expect the same results or similar results to those GLP-1 agonists. So that's why I like this class of medication. The downside is they are really expensive, but of course our GLP-1s are also getting really expensive and hard to find in the pharmacy as well. So something to keep in the back of your mind, but it works the same as the GLP-1 agonist because it increases or promotes the effects of GLP-1 activity. So it stimulates the release of insulin, slows that gastric emptying, decreases that glucagon secretion, increases satiety. So it's really helpful if we can't get patients on those GLP-1s. Contraindications are going to be the same. So we want to definitely watch out for if someone has gastroparesis, it's contraindicated in our type 1 diabetics, heart failure. But when you think heart failure, you're really thinking of those TZDs, right? And then side effects are pretty vague, but generally patients could experience headaches, maybe some chronic congestion, but typically we mostly want to look out for those GI side effects the way we do with those GLP-1s and really watching for signs of pancreatitis. All right. I think, let's see, how are we doing on time? I think this will be our last practice question for the pharmacology. I added some more slides about other medications that you won't see as commonly in clinical practice, and it probably won't come up on your board. So I'm going to skip through those and get to our contraindications after this practice question, but let's go through it together. A patient presents with a desire for medical management of weight loss. The patient has been working on diet and lifestyle changes, but has not had much success and is trying to improve their type 2 diabetes. Which of the following diabetic drug classes may be helpful? Select all that apply. So what do you guys think? Is it A, our TZDs, B, GLP-1, C, SGLT2 inhibitors, or D, sulfonylureas? So what's going to help this patient with their weight loss efforts? I'm so proud. You guys are all getting it right. And these are hard medications to get right. These answers right. You guys are doing great. You guys all got it right. So the answer is B and C. So just a little exam tip, whenever it's select all that apply, just think if you have, oftentimes there's one that pops out at you and you're like, oh, it's definitely GLP-1s, but then think it's a select all, so there has to be at least one more, right? And so that's where it gets a little tricky. So we talked about that a little bit. Remember, those SGLT2 inhibitors also have that weight loss effect. So the answer is B and C. So the SGLT2s and the GLP-1s are going to help this patient with their weight loss efforts. So TZDs and sulfonylureas, they're the opposite. The side effect for this class of medication is weight gain. So in this particular patient, it probably wouldn't be a good choice to start them on. Very good, you guys. So these are the slides that I was going to add in there, but because of time, I really want to get to stuff that's going to be a little bit more relevant for your clinical practice and your boards. These were just nice to knows, and I don't think you need to know, so we're just going to skip past it, and we'll talk about management. So diabetes management, type 2 diabetes management, our biggest thing is our non-pharmacologic management of lifestyle modifications. Remember, we talked about that a lot with pre-diabetes. We still want to focus on that with our diabetics. Help them lose the weight. That really helps with insulin resistance. If they need medication to help them both with their blood sugars, lowering their blood sugars and losing weight, let's get them on those medications, but monitor them on those medications and make sure they're doing the work with the exercise and the diet. Our goals, remember our goal for our A1C in our healthy patient populations, get them under 6.5%. In our elderly, it really depends on how they're doing. So you want to look at the whole picture. In a healthy geriatric patient, you can be as tightly controlled as anywhere between 7 to 7.5 and under. In our geriatric population where they have multiple comorbidities or they have cognitive impairment, functional dependence, these patients, we really don't want to be as strict, right? We need to loosen those goals a little bit and have their A1C be maybe less than 8. I think that's a good goal, and that's what the guidelines say as well, because we really don't want them to be dealing with the side effects that's going to be more dangerous and more harmful to them than their high A1C or their high blood glucose levels. And then, of course, with our pharmacologic intervention or management, we're always going to start on metformin, unless it's contraindicated in that patient if they have renal impairment. But typically, again, very safe medication. Patients do qualify for it. Really getting them on that medication is going to be our first line. And then you can add that secondary drug class based on the individual patient. And then when do you refer? Guys, I don't want you to be nervous about referring patients to endocrinology. Don't feel silly about it. Really, if that patient's complicated, you just can't seem to manage their diabetes, they're non-compliant, you've tried different things, get that patient over to endocrinology. Oftentimes, endocrinology, first of all, these are trained physicians who've not only done training and residency in internal medicine, but also an added specialty, endocrinology. But often in these specialty clinics, they have a lot of great resources. They have diabetes educators that the patient can see insurance covers. They have samples of medication. So if the medication is expensive, but it's a good fit for this patient, they can do that. They have CGM samples that they can just give to their patients. So really getting them over to our specialist is going to be good for the patient and good clinical practice. So don't be afraid to refer these patients, especially patients that are not straightforward, that you're having a hard time with. And then we're going to talk about complications. So why do we treat diabetes? Why do we care if the blood sugars are chronically elevated? Well, over time, when those blood sugars are chronically elevated, it starts to cause damage. It causes damage to both our microvasculature and our macrovasculature. And so here you'll see some examples of damage to our microvasculature. So you're going to see damage to the eyes, to the vasculature in the eyes, right? It can lead to retinopathy, blindness. So we want to make sure they're getting those annual eye exams, they're getting those diabetic eye exams so we can catch it early. Early detection is key. And then, of course, we know diabetic neuropathy. So patients are going to come in complaining, but you want to try to catch it before they come in and complain. Do that diabetic foot exam at each visit, test to see their nerve function. Are they starting to lose sensation? And let's talk about proper foot care. We really want to avoid those diabetic foot ulcers. So if we're getting poor blood supply and nerve damage in those legs, that can lead to ulcers, leads to infection, amputation. So foot care is going to be really important in these patients. Nephropathy, a lot of the medications we talked about today, it involves that renal system, right? So high blood glucose levels, diabetes, puts a really big stress and strain on our renal system. So we really want to protect these patients' kidneys. So let's try to get those blood sugars down, and there are medications that we talked about that can also have an added benefit of protecting those kidneys. And then erectile dysfunction, this goes both ways. So some patients are really comfortable coming in, talking about their erectile dysfunction, they want medication for it. You should be thinking in the back of your mind, well, how is this patient doing overall? How's their blood sugar level? How's their blood pressure? Is this a symptom of that, right? So we want to talk to patients about that. And then same with the other way, you want to ask these questions too. So ask your patients, are they having any performance issues? Are they dealing with erectile dysfunction? And it opens the conversation to really have these patients understand why they need to get their blood glucose under better control. So patient education is our #1 priority, because once we let patients know what we're thinking, then they can really be advocates for their own health and take control of, well, maybe I do want to take this medication. Maybe I do want to be more compliant, right? So it's really going to help open that conversation. And then looking at our macrovascular changes, so look at these big guns: hypertension, coronary artery disease, stroke. I mean, those are not things to take lightly, right? Diabetes increases the risk of all these things. So all that high blood glucose level really increases the hypertension. I see patients coming in with chronic hypertension. It's because their diabetes is not well controlled. They're going to start developing plaque in those coronary arteries. could lead to stroke. So these are really serious complications. So we really want to talk to our patients about this, but also do our part in screening our patients to make sure we're catching things early. So along with that A1C that we're checking, we're also looking at lipid panels to make sure we're checking for any hyperlipidemia and we're treating it. We also want to look at that chem panel to look at their electrolyte function, their kidney function, their liver function. We want to look at those organs, right? We do a urine microalbumin because we've now known for a while that we see some early signs of renal disease in that microalbumin. So we can check every year at least. If it's abnormal, we're going to be checking more often. We're going to do other things, but at least screening every year to really check and preserve those patients, their renal function, preserve their renal function. I like getting a baseline EKG because really patients come in complaining about different things. And so you want to have a baseline so if you see any remodeling or any changes in that cardiac function, you have something to compare it to. Smoking cessation, big one. This is a huge risk factor in our patients. To prevent heart disease, you really have to talk to them about their smoking cessation at every visit. And then making sure they're getting their annual eye exams. They're doing a good job with foot care at home. We only see them once every 3-6 months. They need to be checking their feet at home and talk to them about why. That's really important, and come to us with any changes. So these are going to be our general screening guidelines for these diabetic patients. And our last slide of the day, like I said, I wanted to talk to you about hypoglycemia because we really need to talk to our patients about hypoglycemia. That's when the blood sugar levels are less than 70. So we want to make sure we talk to patients about different causes, symptoms, and what they need to do when they're having those symptoms. In milder symptoms, if they have weakness, hunger, shaking, irritability, they might have a headache, some diaphoresis, we want to make sure they drink their way out of it. So we have that 15-15 rule. So they can drink juice or eat hard candy or sugar packs, but 15 grams every 15 minutes and check their blood sugar and do that until it comes up. Once it comes up, then eat some protein to sustain it. If it's more severe symptoms, so I tell my patients the glucagon emergency kit is similar to like an EpiPen for your diabetes. This is really in a case where your loved ones are going to be using this. If you have passed out or lost consciousness after they've dialed 911, they're going to be using that glucagon emergency kit. So really talking to our patients about different things that can cause that hypoglycemia in addition to their medication. Excess insulin is going to be more about our type 1 diabetics, but skipping meals, diabetics think, oh, if I skip a meal, my blood sugars will stay low. Remember that liver is also involved. It's going to be pumping out that glucagon. So they're going to have high blood sugars and not even realize it. So they need to be checking their blood sugar and they need to be eating, not skipping meals. Excess exercise or excessive exercise can bring those blood sugar levels down. Good exercise is good for helping our diabetic patients, but we don't want excessive exercise. We want to make sure it's planned and we're eating properly. Excessive alcohol intake can also drop those blood sugars. So really educating our patients on hypoglycemic awareness is going to be key in helping protect and protect them and keep them safe. All right, you guys, I know with a few minutes, that was a lot of information. We have a few minutes left. And I'd love to answer any questions you may have about diabetes and how to manage these patients. You guys have been an awesome audience, so if you have to hop off, I totally understand, but you were very engaging today, and I really appreciate that. I think you guys are all going to do a great job managing your diabetic patients. If you have any questions, you can always email us directly. You can follow us on social. We have a lot of free giveaways, and we announce a lot of things on our social, so it's a fun way to stay in touch and keep up to date on all the things that we're offering and as our product is really evolving. We do have a 3-day live review coming up in September. So it's going to be a Friday, Saturday, Sunday. And this is when myself and other instructors will be presenting live from everything A to Z on all the body systems. And so really it'll help you. It'll be a good crash course for getting ready for your boards. We also have on-demand videos in our Q Bank. Our on-demand video are broken down into body systems, so you can go and watch the body system that's relevant to you or that you need to go back and get a refresher on, or you can watch all of it and then go and practice in our Q Bank. So we've got a lot of great products for you. Let us know where we can help you. We also have tutoring, mentoring if you just don't know where to start. start. So reach out to us and we'd love to help you, not only with getting ready to sit and pass and ace your boards, but also getting ready to enter clinical practice, because I know it can be daunting and it's nice to have that support. So we're here for you if you need it. And so let's see. Oh, thank you, Jasmine. We enjoy having you. I've seen your name a couple times, so I'm glad you're enjoying these webinars. Any topics you guys want to see presented that you haven't seen presented, you can also shoot us an email there too. But I really enjoyed talking to you guys about our diabetic management and patients today. So thank you for joining me. And with just a few more minutes, if you guys have any questions, I have my chat box open. I know Rachel's been awesome with helping us in the chat box as well. And I'm just going back a little bit to try to catch up on some questions, but it looks like Rachel's been doing an awesome job. And so if there are no questions, I have a question of my own. So when is the next webinar? That's a good question. So the next one's going to be, what's today, Wednesday? So I think the next webinar is, again, my webinar on Tuesday, September 3rd. And I'm going to be doing a presentation on, it's called From A to Z Primary Care NP. So anything from pediatric to geriatric. I'm just going to do a nice little overview of primary care from peds to geri. So that's going to be on Tuesday. But if you try to think, Rachel, do you know where they can get a good, I know we used to have the QR code where they could scan it and get registered for all our free webinars. Do you know if we have something like that for them so they can see all the webinars that are coming up? But if you follow us on social, you won't miss the free webinars, because I know Sam posts them a couple of days before the webinar is scheduled so that you can register and plan for it. Yes, that's a good point too. So you can go on our website and all the webinars are listed on the website as well. Yeah, and so our on-demand videos definitely have every body system, including endocrinology, a really robust section on endocrinology, including diabetes and all the pharmacology that we talked about today. Any videos and tests? So test taking strategies. Oh, we have a whole video on test taking strategies on the on-demand videos. That's great. I just learned that, so that's good. So I know you guys are still on, so I'm going to ask my question, but where are you? Just shoot in the chat. Where are you in your NP journey? So do you guys have a date for your exams? Are you still in school? Are you just not sure where to start? Let me know. Just graduated, scheduling boards soon. Awesome, Madison. Well, if you schedule it after September 15th, you can join us for the 3-day live review and be feeling confident going into that. So you'll be there. Very nice. Well, we'll look forward to seeing you at our 3-day live review. Awesome. So it looks like some other people are signed up for their state exam. Ooh, an October 2nd date. Very nice. So you can join us for the 3-day live review. You have plenty of time to really get a nice robust overview and then go back and review those sections that you want to review. We get, when you sign up for the 3-day live review, you get the videos for 30 days. You get the recordings for 30 days after the review. So you can really go back and watch the sections over and over again, which is really nice. I usually tell people, well, even if you can't attend live, register for it because it's a really nice deal. And then you can just go back and watch the videos when you get a chance. Yes, and as Rachel pointed out, you get unlimited access to us. So that's true. We have more time in the 3-day live review for big Q&A sections, and you can ask us more questions directly. So definitely a nice time to really talk to the instructors and get your questions answered. So there are different bundle packages if you're looking for the on-demand videos along with our Q bank. You can go on our website and look at all the different options. But we have combo deals where you can purchase the Q bank and on-demand videos together. You can purchase them separately. We also have the Sure Pass, which gives you all three now. It gives you the 3-day live review, the Q Bank access and the on-demand videos, and it's under $200 or something like that. It's like an amazing deal. So go on the website and you can see all the different deals and see what works for you. But our goal at Archer is to make it affordable and effective resources so that we can help support the nursing community. So if you can't find something on there that you're looking for, shoot us an email to our general Archer email, but we've got some really good deals on the website. Yes, and Rachel just posted the link there, so that's great. Thank you, Rachel. I don't know what I'd do without you. Be my chat support on September 25th. All right, you guys. Well, you were a wonderful audience. We're about 5 minutes over. I don't see the 3 inclusive combos. Jasmine, if you go under SurePass, so there should be a link under SurePass, and that's when it adds all 3. We're changing the language a little bit, so it's pretty clear that it's all 3, but it's called SurePass, and that's when you get the 3-day live, the Q Bank, and the on-demand videos for under $200 is like that first SurePass option. But good question. All right, you guys. Well, we're about 5 minutes over the hour. Thank you so much for joining me today. Thank you for hanging on. I know we went a little bit over, but I love answering your questions, and I really had fun presenting to you guys today. So we hope to see you again at our next webinar on Tuesday, September 3rd, and we have a lot of good things coming up for you. So follow us on social and you won't miss any of them. But enjoy the rest of your day, you guys.